the percentage of doctors that are over the age of 60 has reached like 45%. Doctors and nurses have left the workforce actually in droves because of that burnout issue. We're at a breaking point where the industry needs these solutions. My big idea is what we call super staffing for healthcare. And what that means is, we've talked obviously about just the rampant challenges that exist in our healthcare industry. So much is broken about it. But really one of the sort of underlying fundamental issues that we face is this supply-demand mismatch between the amount of clinical supply that we have in the forms of doctors and nurses and other clinical service providers versus the level of demand that we as patients represent in the industry. And it's not just that the demand itself is high, it's that the nature of the demand keeps getting more and more complex. We've talked a lot about how the chronic disease burden in America is increasing over time. The number of diseases that any individual has is growing and growing. The number of drugs that we're all taking is growing and growing. And so again, not only is it that there's just a shortage of labor relative to the number of humans who need it, but also the nature of the work is also getting more complex over time.
So let's dive into that. Just how short are we in this clinical staff?
Yeah, I mean, there's a lot of different numbers here, but I think generally speaking, when you look at, for instance, the number of doctors that we have estimated a shortage in, it's anywhere between, let's call it 60 to 100K doctors today, as of today, in terms of the relative demand that we have in our system, and roughly about 75K to 150K nurses. But I think probably one of the more interesting issues to unpack here is what do we actually mean by shortage? So there's largely two schools of thought of how people define this. One is simply the number of human clinicians that we have is one way to look at it. The other way to look at it, though, is given the number of nurses and doctors we do have, are they actually fully performing to the full extent of productivity that number of laborers actually represents? And I think it's probably at the end of the day a combination of both, but those are two different ways that people have cut that pie.
And how did we get here? Like, if we think about it, a lot of people talk about population dynamics, right? A lot more people are getting old. But then there's also this maybe dynamic of just a skill shortage. And as you kind of touched on already, maybe what we need today is different from what we needed 10 years ago, 20 years ago. What is leading to this shortage?
If you zoom out the lens entirely on, this highly regulated industry, there's actually a structural and regulatory constraint on the amount of supply that we allow into the industry on any given time basis.
Right, through education, you're saying?
Education is one. Certainly, the number of accredited medical schools is constrained, both in terms of actual accreditation, but also in terms of funding. Standing up of medical schools is actually funded by federal dollars, and there's just a physical limit on that. The other version of that is licensure. So once you get through your training, you have to be licensed at the state level to be able to practice medicine. And again, there's only a certain number of licensures that are approved on a given basis. You have to renew that every few years. So there's, again, like just sort of structural constraints in the industry level that constrain the supply side. In addition to that, once you are a doctor, there's all sorts of challenges, some of which you alluded to, of the job itself that have led to constraints. One is certainly the aging population. There's a ridiculous stat that in the last couple of years, the percentage of doctors that are over the age of 60 has reached like 45%, which is crazy. And so there's this huge kind of silver tsunami dynamic of what happens when all those doctors retire. There's going to be a huge gap just purely on the basis of age. There's also the burnout issue. Just given everything that happened during the pandemic in particular, we put so much burden on our frontline staff, and what we were asking of them to do was obviously very challenging. So doctors and nurses have left the workforce actually in droves because of that burnout issue. There's lots of surveys that show that upwards of 80% of doctors and nurses will say the number one issue in their lives is burnout due to their jobs. And again, another ridiculous stat, upwards of 300,000 clinicians left the workforce in the year 2021.
This is in America specifically?
In America alone. And even in the last couple of years, about 7% of the country's total active physician workforce left their day jobs as being clinicians. Even if we're able to train like 100% of the capacity of our medical system, of our licensure system, the folks are just not sticking around because the job itself has so much overhead. The last thing I'll say is that doctors are increasingly taking on more and more administrative functions and academic functions. So another sort of amazing stat is I used to live in Boston. Boston is actually the highest density of physicians in the entire country, but they have the worst access issues because the vast majority of doctors there are working in academic environments. So, more than half of their time might actually be used on research, not on actual clinical activity. So I can go on, but these are some of the reasons why even if you were to look at the number of doctors and nurses, there's a lot of other factors that play into the actual capacity that's represented in that pool of labor.
Yeah, and I want to get into how we maybe solve that with technology, but maybe we can also just quickly speak to what the patient feels, right?
Yeah.
All of us, is it longer wait times at the hospital? Is it more expensive procedures? Is it not being able to even get healthcare in some cases? Like, can you kind of speak to the second, third order effects that ladder down to the everyday person?
Yeah, I think the most obvious issue is wait times. And there's studies that show that the average wait time for, let's say, a specialist appointment across the country is like 50 days. And it can range from like 27 days on the bottom end and up to like 90 days on the high end, and even worse for certain subspecialties. And so that alone is obviously an issue. The other related issue is that even when you're able to book an appointment, let's say a month out, there's data that shows that after the second week, like after 14 days, basically the no-show rate goes way up, right? Because your likelihood of actually committing to that date and not canceling or not just showing up altogether goes through the roof. And so one of the, kind of exacerbating issues is that these slots are booked and therefore, the doctor is kind of saving that time. But a lot of that just goes unused simply because the patients aren't showing up because they've waited for so long for those appointments. To your second point, what happens is that, if I have an issue and I need to see a doctor immediately, the longer I wait, the longer the chances is that it gets worse, right? I might end up in the emergency room, which obviously can be, 10, if not 100 times more expensive to our healthcare system than that initial physician visit. And then certainly, another sort of issue, especially just given how much is happening around the consumer healthcare landscape these days, the other challenge is that, the less easy it is for you to see an actual doctor, the more likely that you're going to go online and try to self-diagnose and, get advice from folks who might not be medically
Dr.
qualified.
Google.
Exactly. And so those are some of the major issues, but I think the wait time piece is like kind of the underlying fundamental challenge that leads to all these negative outcomes.
Yeah, and you just spoke to like this idea of Dr. Google, and that's where technology maybe is not playing the right role, but it sounds like technology maybe can play a better role. I just love to hear your take on that. Like, is it realistic that technology can actually come in and curb some of these issues?
Yeah. I think that the way to think about it is sort of absent technology, how would we solve this problem? And, I think it boils down to like, how long are we willing to wait to solve this problem through just simply growing the supply side of our market? And also at what cost, right? To, sort of take those 7 to 10 years to like fully train a doctor is not a cheap endeavor. And so that's really where I see the opportunity for technology is to say, listen, what if we just assume that there are a fixed number of clinicians in our system? And if we just have to go with like the number of doctors and nurses that we have today, how can we increase supply and capacity? Well, there's two ways, and this is where this super staffing concept comes in, is how do we super staff by enabling every individual provider to be able to be more productive in their day-to-day work. So that could come in the form of things like co-pilots. How can I ensure that the amount of time that a given doctor is taking to make any given decision at the point of care in real time can be shrunken down such that they are just far more efficient with their decision making, and that the caliber of the decision that's being made can be at parity with, again, the best of their peers on the basis of, sort of great data and great decision support. So I think co-pilots is one way that you could imagine unlocking, additional capacity within the current existing pool of clinicians. And then a second vector, which is a different form of superstaffing, is how do you augment the current labor pool with autonomous agents? And largely the form that that's taken today is if you were to unbundle the job of a doctor or a nurse, there is a very significant portion of what they do on a day-to-day basis that has nothing to do with patient care, that has nothing to do with the use of their unique clinical judgment. So can you take those tasks, largely administrative in nature or just communications-based, and unbundle those and give those to an autonomous agent to then do at much better scale, with much better accuracy, with much better reliability, such that, again, the clinicians can actually focus on what they do best.
And do you have a sense of what portion that is? Like, I know it will differ based on specialty and doctor, but like, are we talking that this administrative portion is like 3% or is it 30%?
It could be upward of 50%. Like half of their job is mired in these, clerical tasks that, again, take their time away from actual care delivery. So, imagine like almost doubling the capacity of a given clinical labor pool simply by applying some of these unbundling tactics.
Are we seeing tools like this already on the market? Where are we in the trajectory of LLMs or AI in particular entering this industry and actually reshaping it?
Yes, and this is what's so exciting right now is that we are truly in like a golden era of healthcare technology adoption. And one of the dynamics that we believe is driving this rapid adoption cycle of these new AI tools is what we call this kind of leapfrog dynamic, where healthcare historically has been a laggard with respect to software-based technology. And we've always thought that that was sort of to the detriment of our industry. And, everyone else has these great workflow tools, these SaaS products. Because we didn't do that as an industry, we don't actually have the sunk cost bias that other industries are facing right now, where they say, like, we just spent billions of dollars laying out these workflow tools. We trained an entire generation of our workforce to use these workflow tools. And now we're being faced with the decision, okay, gosh, do I need to spend yet another $1 billion on these new AI products, completely rip and replace this last generation of technology capabilities and retrain my workforce on a whole new paradigm of how they do their work? Versus in healthcare, where we're just simply leaping from we can't throw enough bodies at the problem to how do we actually augment our bodies and extend, the number of bodies through these AI capabilities. And so we believe that that's driving a lot of the rapid adoption cycle that we're seeing right now. There's a few examples of this. So I mentioned kind of co-pilot versus autonomous. On the co-pilot side, there's this class of products called ambient scribe products, where it's a way for a doctor and a patient to be having a visit, and there's an ambient scribe literally listening. So the doctor can actually make eye contact with you. They're not sitting there on their laptop. And that AI scribe is specifically tuned to be able to translate that conversation into medical documentation that is compliant, that facilitates billing in the appropriate way, that completely captures the clinical context of that particular encounter, and then can be saved directly into the electronic health record. And so that is a class of products that has really taken off. My doctor friends that I talk to are all using, one of these products. It's completely transformed their lives. They're getting back hours of the day that are no longer being spent doing manual documentation, which is a requirement of their job. Another example is sort of a class of autonomous communication platforms where, one of the biggest ways by which the healthcare system communicates with us is through call centers, right? And so there's companies like Hippocratic AI in our portfolio that has built an army of super staff, of folks who can actually play the role of either an outbound, call center agent that is trained on very specific protocols that are infinitely patient and can actually execute a number of tasks that otherwise would rely on humans to do. And what we're seeing is it's remarkable. Number one, most hospitals have about 10 to 20% of their headcount open at any given time, and they simply just can't find enough people to fill those roles, namely in the call center setting. And so what they're saying is, gosh, if we can't hire people fast enough, how amazing is it that we could spin up, not just one or two, but 10 or 20 of these autonomous AI agents that are actually, again, doing the same job as these humans would do. And what's also incredibly interesting, and part of, the why now for why we think this trend is going to be at a tipping point, is they're starting to say, okay, why can't we just pay for this out of our labor budgets instead of our IT budgets? And one of the historical constraints with healthcare technology has been that the portion of the budget of, let's say, a hospital that's spent on IT has been a tiny fraction of what it is in other industries. The average is like 2 to 5% of budget goes towards IT in healthcare versus like 15 to 30% in like banking or financial services.
Sure.
And so now we have this huge unlock opportunity to say, rather than be constrained by that tiny IT budget, what if we tapped into the 60, 70% labor budget and actually be able to create, additional leverage by deploying AI in that fashion? So these are some of the fascinating trends that we're seeing already happening in market that sort of demonstrate, the sort of rapid adoption cycle of these new AI products.
Is it just that there is such clear demand to fill these roles that we're seeing something different today? Or why does it seem like there has been this adoption or like jumping to participate in this AI wave when we didn't really see that in the past wave?
There is just a very high burden of integration, right? Like at the end of the day, if you're going to be introducing a new software tool into someone's workflow, it has to deeply integrate with, an EHR type system or whatever other, practice management system they might have. And, those systems are 40, 50 years old. They don't always have great APIs. And so just the amount of work and time and sort of customization that's necessary to get those in has been a huge barrier to adoption in the past. The second thing I would highlight is that these are just magical products, right? We have a company called Ambience Healthcare in our portfolio that creates one of these ambient scribe tools. And when you look at the testimonial videos that they have from their doctor users, it's unbelievable. I mean, these folks are like literally in tears saying that it's, if they've been a doctor for 30 years, it's like the first time that they've actually enjoyed the job of being a doctor because it's just allowed them to focus on the patient. The last waves of technology products that have been given to them have just increased the amount of complexity of their jobs, whereas these are doing exactly the opposite.
Are there challenges, though, to actually implementing this that you're seeing on the ground, whether it's the tools today or the things that you see on the horizon?
The stakes are much higher, obviously, in the healthcare setting.
Yeah.
And, the hallucination issues that you see with kind of the generalist foundation models, like that is just a non-starter. And so what we have seen, and perhaps why there was maybe a little bit of lag relative to some of the generalist foundation models in terms of adoption in healthcare, but these companies that I'm describing have built specialist models in healthcare. One of the issues with the generalist foundation models is that, not an issue, it's obviously a huge feature that they are trained on internet data, like the entirety of all publicly available human knowledge. But what the reality of healthcare is that the majority of sort of the esoteric, protocol-specific, compliance-specific information tends to not just be online. It tends to be in these proprietary systems, behind the firewall, embedded into paper-based binders and things like that. And because of that, it is necessary for these companies to build specialist models that are trained on a different set of data. Then they might extend, some of those foundational model, generalist models, but they do need to ingest a different set of information and specifically be tuned for safety, right? And so people do need a specialist approach to tuning the foundation models to perform appropriately in this setting. Another one would be exactly what you said, the regulatory compliance issues associated with the use of autonomous AI in particular, and how that bumps up against FDA approval criteria. Under what circumstances do you need to get a AI tool approved by FDA or not?
That's interesting.
It's somewhat.
Do you?
Yes. In fact, one of the benefits that healthcare has had is that we are the only industry that actually has an existing regulatory framework for approving products, especially in the clinical setting. So there are already hundreds of AI radiology models or, other models that sort of help automate the assessment and diagnosis of a given set of patients based on a certain area of medicine. But how does that apply to a Gen AI model? There's a lot of work being done right now by the FDA to really extend those models to be appropriate for these far more dynamic systems that just have a lot more uncertainty than your standard kind of ML predictive model modality, which is really what that system was designed for. The last thing I'll say is reimbursement. There are some early signs that insurance companies are creating actual billing codes for AI, where they now say that, an AI-enabled, visit or an AI-enabled diagnostic can now be reimbursed differentially, and you can get, sort of credit for using these AI systems in a different way than if you were just, not.
Sure.
And so that's really exciting to see these new paradigms persist. But I think there's still very much a long pull until we have the ability to say, okay, if I have a fully autonomous like AI therapist, it's like Slingshot AI, which is one of our portfolio companies, how can we ensure that those will be systematically reimbursed, at least at parity with what a human therapist might get reimbursed for? That has yet not been defined in our industry. So I think there's a lot of good early signs that there's a willingness by the system to embrace these new paradigms, but still a lot of wood to chop in terms of defining a comprehensive set of ways to get that in.
Do you think that this has the potential to kind of even reshape the ecosystem that already exists and not just augment it?
Yeah, I think there's a lot of really amazing things that are now possible to do. So one really interesting one is just, part of the constraint of our current clinical supply is that we do have state by state licensure, right? So if I become a doctor, I'm basically constrained by my geography. And if there's a poor patient who, happens to need my services in Montana, and I'm not licensed there, but I do have capacity, I'm not able to serve that person. I think what this whole kind of AI world unlocks is imagine that you had national scale capacity, and the sort of the routing challenge becomes a really unique one that actually could leverage AI, right? So there's this new concept that actually one of our portfolio companies introduced called asynchronous medicine, which means, okay, the typical way we think about, seeing a doctor is you show up at their office, it's a 30-minute visit, it's face-to-face and live, and it's highly transactional though, right?
Yes.
So you're in and you're out, and then months might go by or years might go by between visits. Whereas asynchronous care is something that completely flips that paradigm on its head and says, what if your doctor was in the cloud and any time of the day, 24/7, you could text them, you could, send them a message, and they would respond, in near real time. But the level of sort of ongoing engagement that you can have, like the friction to any one encounter with your doctor goes way down because you can text them at any time of day. And that's a new paradigm that, again, is kind of purely enabled through these AI-powered clinic models where you can have these doctors who are available, 24/7, who are using AI as co-pilots to enable them to be hyper-responsive to any question that comes in. And so I do think that the nature of maybe how doctors do get trained and like what specialties actually exist that don't exist today, I think a lot of those contours are very dynamically changing as we speak.
Since this was your big idea for next year, is there anything that you're specifically looking out for or excited to see?
We've just never seen the rate of technology adoption that we're seeing now ever in the history of healthcare IT. We've been waiting for these moments to sort of take what we know to be the problems and we know what the solutions can look like, but there's just been, again, like this sort of a barrier between the problem space and the solutions. And, I think what we're seeing now are signs that perhaps that wall has been broken. We're at a breaking point where the industry needs these solutions, and therefore we're going to see much higher adoption than we've ever seen before. I think it will come in the form of these super staff. I think we will increasingly see adoption of these AI tools in the form of labor and, coming from completely different budgets, from completely different buyers than we've historically seen. And, I think this is all to lay down the groundwork to truly unlock the latent capacity that we have on the supply side of our market that's been sitting there all along, but just hasn't had the right technology modality to unlock it at scale.